So I will try not obviously to say the same thing that what I said earlier this morning. I really think that we should have a hard team approach in most of our cases. And as I said, these guidelines were developed as a hard team. And it's interesting if you compare with our American friends' guidelines, you have two different guidelines actually there. You have PCI guidelines and you have CABG guidelines. Thanks God, the chapter on stable CAD was developed and written jointly, so you have the same recommendation. Otherwise, the whole process does fall apart if you have different things. So what I would like to emphasize here, not talk about the table of contents anymore, is what should we bring to the hard team? Now, the first question is, I mean, who should be part of the hard team? And I mean, like, when Leslie didn't raise his hand because we don't have in his center, they don't have a non-interventional cardiologist in the hard team, and probably when we ask this question, we should ask two questions, one with and one without. And I think that to have the discussion with a non-interventional cardiologist is rather interesting, especially when it's the referring physician who has known the patient for a long time, because I think that the patient will trust this person. That's important. The second point is about patient with a more complex CAD. Well, there we should try to include other specialties. I mean, you are not going, obviously, to have 5 or 7 different medical specialties involved. But I think that to have a geriatrician, if you talk about a patient with 80 or 75, it can be reasonable. Rehabilitation specialists, the GP. The GP can also be important to liaise with the patient and with the family. And I think it's rather important. Now, I saw another slide earlier this morning implementing, you know, carekeeper, social workers, and so forth. And I mean, in some extent, it can be interesting. I mean, obviously, you don't want to blow up the size of the team and to reach 15 people. That's not possible. But I think in some instances, it's important to expand it. Now, we come to back to this 1C recommendation, that patient be adequately informed and that the appropriate revascularization strategy should be discussed by the heart team. Well, now, a couple of questions is what is informed? And the reason why I want to emphasize that is because I think the heart team should know what the patient knows. Okay, what type of information was brought to the patient? So what means to be informed? If I say, well, if you got CABG, that's how you would like 24 hours after the operation, and that's how you would like 24 hours after multivessel PCI, I'm not quite sure it's informed. I'm not even sure that this lady is there in the Brighton sun in March had a PCI the previous day. That's a little extreme. So what we did in the guidelines is to develop a patient information document. And this document says what is important, what is significant about CAD, how can it be treated, optimal medical treatment, sometimes it's enough, PCI or CABG, and what are the advantages or disadvantages of either technique at a glance. And this document is actually freely downloadable from the ESC and EACTS website, and it has been translated into some languages like French, Dutch, and German, and Spanish, I think, and it's quite important. And in this document, you have a nice picture like this one, where it is quite easy to show the patient the major difference between the two techniques. When we do stenting, we put a stent in the lesion, and we don't work on the proximal or distal lesions, while a bypass surgery, by definition, doesn't treat the lesion itself, but it's a bypass. Now, the 4 principle plus scope of medical ethics provides a simple, accessible, and culturally neutral approach for the thinking about ethical issues in healthcare. And it is based on 4 common basic prima facie moral commitments: respect for autonomy, beneficence, non-maleficence, and justice, and the scope of application. And that's actually a almost 20-year-old study published in the British Medical Journal. It's a general concept. It's not about coronary artery disease. It's about any form of disease. But I think it's something that we also should think about. Now, what is respect for autonomy? It depends agreement before action. You know, Well, it's too late if we say we have done that, I hope you agree, I hope you don't mind. Demands for communication, and we are in the society of communication. We communicate all the time by different means. Telemedicine is one. For example, if we don't have multidisciplinary team on site, you can communicate using telemedicine, teleconference. The patient would like to have participation in medical decision-making. I understand you had a session with 2 patients that were involved yesterday, and I think that's great. And I think that that's something we should do more and more at a European level. And demands for informed consent. You know, if the patient has seen for a few minutes the picture I showed you, it's probably better for him to give or her to give informed consent after that. So the second question is, what is time? What does it mean, time? Well, obviously, it's something that's very variable. And from that, we gave this recommendation of ad hoc PCI. I will not go through again. But ad hoc PCI is obviously extremely interesting from an economic point of view. It is certainly appropriate to discuss ad hoc PCI within protocols. And I think that one of the first tasks of the heart team should be to define those protocols by which we all, as a team, including cardiac surgeon and non-interventional cardiologists, agreed upon what should be defined ad hoc. As I said before, the recommendation that we give for ad hoc, they were the recommendation from our team, from the task force that developed these guidelines. There's not a lot of question about the first two lesions, culprit lesion in acute events and unstable patient from a hemodynamic point of view. But when we look at stable patient with proximal LAD, that's where we should discuss. That's either put it ad hoc in some cases or revascularization at an interval in others. So I really don't think that just mentioning ad hoc PCI for economic purpose, because it's easy, that's for example something we hear a lot in Germany, it's not appropriate. It's not enough. There are other ways patient can be discharged, readmitted with another admission, and that's not an economic problem, really. And revascularization at interval, I already mentioned what's possible, and hospital team without a cardiac surgical unit, that should be discussed. Now, a second point I think that we should really discuss within the heart team and have this information available is the score, the risk score, so the clinical risk and the anatomical risk. So what we did say in the guidelines, we look at most scores available in 2010, Euroscore, Syntax score, Mayo Clinic risk score, NCDR, CAT, PCR, Parsonet, STS, and LSEF. And you can see that actually 3 scores are interesting. 2 are clinical score, the Euroscore and the STS score. The Euroscore is rather old, the first version. Patients were included in 95 and the score was published in 98. There is a new score that was published last year in 2012, so it will be incorporated in the new version of the guidelines. The new score hopefully will be closer to reality because the former Euroscore used to overestimate risk usually, and especially in high-risk patients. The STS score is extremely interesting, although it's not mandatory, it's a voluntary basis. I think about 50% of the procedures are recorded in the States. And it is undergoing periodic adjustment, making longitudinal comparison somewhat difficult. But for CABG, both Euroscore and STS score are well validated, mostly based on clinical variables. On the other hand, we have the Syntax score. It's not a risk score, as mentioned earlier, it's an anatomical score. It will quantify the complexity of the disease, and I agree that probably 5 or 10 years down the road, the classification into tertile may change. I mean, obviously, 3 tertiles is somewhat arbitrary, but it was the easiest way to go. So we have Euroscore and Syntax score. The Euroscore is based on, at least the first Euroscore, is based on 17 clinical variables. And validated outcomes include short and long-term mortality. The Syntax score does not have clinical score. We have 11 angiographic variables per lesion. It's very complicated, per lesion. And it does, as said, quantify coronary artery disease complexity. So what would be interesting is to look at the complex interaction, the prognostic interaction between these two scores. And Sarais and so forth are coming with a global risk stratification. Why not combine Euroscore and syntax score? And you don't have to have something like that. Euroscore low, medium, and high. Syntax score low, intermediate, and high. And that's where you would go. And I think we need, obviously, trials to validate or not these concepts. And the reason why I'm emphasizing this in this talk is that I think these scores should be available in the heart team. Clinical score and syntax score. And this is probably one of the most important information that we need to have available in a heart team discussion. Now, this heart team, if we have no heart team in a hospital, or if we want to change according to the guidelines, what are the tasks for the local heart team? To define standard protocols compatible with the current guidelines to avoid the need for the systematic case-by-case review of all diagnostic angios. It will go into the direction of clinical pathways. To design protocols that define specific anatomic criteria and clinical subsets that should be treated ad hoc or not. To organize morbidity and mortality conferences, to find out what happened with those patients that had PCI or CABG. To review institutional results in all transparency for benchmarking and guidance in decision making. So it's not only discussing about current and future patients, it's also about reviewing results, and I think it's very important. You can merge, actually, M&M conference with the heart team. To ensure proper patient information and consent, including adequate discussion of alternatives, risks and benefits, and then you have the scores, clinical and angiographic. Short and long term, avoiding anonymous treatment. We're not saying that the patient should come to the heart team, that's not the question. The patient, obviously, should be presented a digested and common opinion. You are not going to fight in front of the patient, that's not the idea. So the key points are regular heart team meeting. It depends on the size of the hospital, how many procedures we do. Sometimes once a week is enough, sometimes once a day is needed. Anything in between once a day and once a week probably. We need systematic scores calculation, both angiographic, and I think it's also very interesting for a fellow, both in cardiology or in cardiac surgery, to learn how to calculate a score, a syntax score, for example. It's extremely interesting to realize that, for example, if you have full occlusion, bifurcation, diabetes, not diabetes, but calcification, whatever, eccentric lesion, the score will change. Revascularization should be based on functional assessment, so we should have this information available. And in the heart team, we should know what information reached the patient. I think it's also very important. Thank you very much.